Welcome to Genomics Gupshup. Genomics Gupshup is an initiative by MapmyGenome to create a community around genomics and to simplify genomics for everyone. And we do this by bringing together experts from allied areas like medicine, genetic counseling, nutrition, fitness, and more. Please join us as we spread the word about this exciting science of genomics. We are now available on your favorite podcast as well. Just search for Genomics Gupshup on Apple Podcasts, Spotify, Amazon, or Google Podcast. This is the 41st episode of Genomics Gupshup, and I'm so glad to welcome Dr. Niraj Krishnamurthy. Dr. Niraj is one of the top obstetrician and gynecologists with more than 20 years of experience. He's currently a senior consultant OBGYN and endoscopic laparoscopic surgeon at Rainbow Hospitals, Hyderabad. He has worked in so many reputed hospitals in India as well as in the UK. And his experience in the OBGYN field is truly exceptional. And we are so eager to delve into this fascinating world of women's health and genomics with him. So welcome to the show, Dr. Niraj.
Thank you, Anu. Thanks for that nice introduction. And I must thank you also for having me on your show, which I feel privileged to be a part of. And I look forward to the conversation. Thank you.
Thanks so much, Doctor. So, Dr. Niraj, I'm always curious, why did you, choose this this area of becoming an OBGYN in the first place? Is that something that you always wanted to do? Is that something that came up as you went along the medical field, or how did that all come along?
I think as a medical student, when you're doing your MBBS, there are lots of teachers or seniors around who you somehow subconsciously set them as your idols. And you think, this is how I want to be. Then you suddenly, the next day, the idol changes. You feel, no, this is what I want to be. So as far as the inspiration was concerned, there were lots of people who would have inspired into different specialties and different fields. This was one of them, obstetrics and gynecology. But one thing which one of my lecturers at some point had said, which struck a chord, was she said obstetrics and gynecology is the only specialty where you look after two lives at one time. There is no faculty, no discipline in medicine which will look after two lives at one time. There'll be all the specialties will look after one life at a time. We look after the baby and the mother both at one time. There have been several occasions where we were involved in saving both lives at one time. So that kind of thing really appealed, and I thought, why not really do this? So that was, in a way, I think, more a pushing factor towards that, because there were other competitive areas as well which I wanted to be. But this was one thing which I thought will be more exciting to do, and that's how I ended up being an obstetrician and a gynecologist.
And so first you were in the UK as well as in India. So where was you initially practiced in the UK, or?
No, my training was in Government Medical College from Nagpur, and I did my post-graduation in MD from there as well. After that, I was very keen to upgrade my knowledge and skills and have an exposure from one of these countries. And UK was always my main area of interest in terms of going there and getting myself trained in. So fortunately, I could get the right score where I wanted to. I had to give some qualifying exams, which I had to go to Nepal for those exams because we did not have center in India at the time. So those qualifying exams, fortunately, I got cleared. And then I had some consultants in Bombay who were very keen that I should go to UK. So they kind of supported me in terms of writing references and finding the right people where I should be working in London. And that's how they made sure that I go there and actually learn the specialty into more details and get exposed to the whole new academic as well as clinical areas. So that's how I went to UK. I mean, that was always a desire, and fortunately, right things happened at right time, and I could go after my MD and did my training there as well.
But what got you back? You always wanted to come back to India, or was that?
That's a debate which most doctors like me who have returned or those who have not returned always think about. There are many people abroad who I know, my friends from medical field as well as non-medical field, who are keen on returning to India. But after having spent a few number of years there, you don't gather the courage or the drive to wind up everything and come. But somehow we were always keen on coming back to India and trying to try and serve the people here, try and use your expertise here and live a life in India. That is how we always wanted. So we, even after living for 12 years in London, having had trained there, we could, and my wife obviously was very supportive of the decision. We wanted to come back as a family, and so no, we have no regrets of coming back. We always wanted to come back, and here we are, happy doing what we wanted to do always.
I'm so glad that you came back. I think it's good for all of us over here. So Dr. Niraj, I'm sure you see a lot of difficult cases, right? I mean, I know that, I've gone through 2 pregnancies myself, so I know that, and mine were very easy, relatively. But I think
Neha and Akila.
Yes.
Yeah, sure.
I mean, I'm sure you've gone through some really tough cases. So can you talk a little bit about, anything that, struck you as being particularly difficult or interesting in your opinion?
Now, how shall I say, over almost 25 years of clinical practice, there have been numerous occasions where I would have gone through, and like me, many of my colleagues have gone through several experiences. It's really difficult or impossible to kind of summarize them and say these are the cases. It will be clearly a book I can write, or we can write about our experiences in the specialty. But there have been certain occasions where many obstetricians would retire not having been or seen in certain conditions. I have been in situations such as those. One of them is what we call perimortem cesarean section, pericardiac cesarean section, which means someone has collapsed in front of you, the mother, pregnant mother, and she would die if you don't deliver the baby literally there within few seconds. I was involved in 3 such cases in India, where 3 different occasions within a span of 2 years, I found myself in those situations where I could save both the mother and the baby. And if literally few seconds would have mattered, and we would have lost both the mother and the baby. And we have this situation now where I have all these women alive and all the babies alive, kicking, doing well. Off and on, they keep sending me the pictures of the babies, pictures of the mothers, and just showing their gratitude and thankfulness. So it's a very rare thing. In fact, you can find obstetricians who will have retired and not having had seen a situation like this, where you are doing a cesarean section, not in an operation theater, not in the most ideal setups, but just in waiting hall of the patient. I have delivered mother who was collapsed in front of everyone, and people were there. I took a knife and just opened her abdomen and delivered the baby, and the resuscitation process went very well along with my anesthetist colleagues. And we could send the mother and the baby home, both of them. And literally few seconds or few minutes would have mattered, and we would have lost both of them. Fortunately, and very rare again, 3 situations I was involved in, and we could send all 3 of them home, or 6 of them home. And this happened in 2 years, between 2012 and 14 in India. So that's something which is a very satisfying experience. There have been several occasions otherwise where we have really saved lives, but this is an exceptional situation to be in.
So is there a particular reason why that happens, or it can happen like, can people anticipate something like that to happen during?
So 2 of them actually had underlying cardiac disease, which was undiagnosed, which was not picked up during pregnancy or even in their early life, which got manifested during pregnancy, because during pregnancy, the load on the heart also increases along with other systems. And that heart could not really cope with the increased workload of pregnancy. And that's how they just collapsed. So this we found out later during the course of investigations as to why it happened. So 2 of them had that, and one of them had absolutely no reason. I mean, eventually we found out that she had a clot in the lung, which she had, because of which she collapsed. But 2 of them had underlying cardiac conditions, which was undiagnosed, not known during pregnancy or prior to pregnancy.
I think that's the interesting part, right? Like, I think a lot of times we don't even realize that you are kind of sick in some way.
Yes.
Because I think you only go to a doctor when you are like really sick, or you're pregnant, or something like that.
True. And what happens also is, most of I don't call them patients. I hate calling these pregnant women patients. I call them pregnant women. Making a healthy woman getting pregnant doesn't become a patient. she's still a woman who's pregnant. So she's not a patient really, truly, because pregnancy is not a disease. It's not disease which we're treating. It's a normal physiology. We just support, as doctors, we just support a pregnancy. Of course, if there are problems, of course there are, if there are any issues during pregnancy and it's not going on expected lines, then we step in. But essentially, all these pregnant women are pregnant, healthy, fit women. So these women have the tendency or the capacity to cope with a lot of changes in the body, because they are all fit young women. I mean, those who are, say, 45 and beyond and then get pregnant, they are rare, but I've seen that. Those are the mothers who need more special care because their body physiology does not support pregnancy the way we want to, or the way a 30-year-old would cope or a 25-year-old would cope. 45, 47 would not, because of the natural process which we all go through. So those are the women who I would say need more attention or more care. Otherwise, these are all fit young women. So they kind of cope with many problems without any support.
You mentioned that, you've seen women who are coming to you at like 40, 45, or their pregnancies at that age. Are you seeing a slow progression towards later pregnancies over the last few years, or is it something that was always there in some percentage, but now the percentage is increasing?
Certainly, it has certainly increased, especially in the setup which we are working in the urban middle class or the upper middle class, where women have become more career oriented. They are working women. Most people are marrying late, and most people are actually planning pregnancy late because they want to settle their careers first and then focus on the family. This is completely contrast to what we used to have during my training days. For example, 30 and above, we used to say, there was a term which I hated, but we use elderly primey. Elderly primey meaning elderly mother first time pregnant, which was 30. Now 30 is not considered as an elderly at all. I mean, 35 is, 35 has become more of a norm. I see many women 35 who are pregnant, which used to be 30s during my training days, or even 10, 15 years back, I would imagine. But yes, there is a slow progression towards later pregnancies, both for career reasons and for social reasons, I would imagine.
I mean, I remember like I was in my 20s in my first pregnancy, and the second pregnancy I was in my 30s. And there's a lot of difference in terms of the kind of tests that were recommended for me. And also, I think one, I was in the US, the second I was here. There was a little, it was different in terms of, how you approach somebody who's over 30. And I guess now over 40 will probably have a lot more number of things that you want to test for in a prenatally as well as postnatally, right? I mean, so that is, I guess, normal physiological changes.
True. But one more thing, actually, our country is so diverse that this I'm talking about the urban setting in middle class settings.
And are a lot of women keeping their eggs for future this thing as well, or is that still not yet a
no, that hasn't yet become a norm. That hasn't yet come that big way. But there will be medical conditions where, for example, malignancy, someone wants to remove their ovaries, then the egg freezing and all that thing comes. But fortunately, that those situations are rare.
Still rare, even in cities like Hyderabad.
Yes. Yeah.
So I saw one of your videos, and that was on recurrent pregnancy, like abortions. Now, in your opinion, I know there are many causes for that, but can you like summarize some of these causes? Some of them are genetic, some of them are non-genetic also, right? So because we see a lot of people who, typically a lot of parents who have a pregnancy loss, and then they come back to us to understand the genetic reasons later on, right? Like during the second pregnancy or something. But I'm sure you see a lot more than we do on a regular basis. So what are the typical, like, do you see a lot of, what percentage of them would be genetic in terms of the cause, and which ones would be non-genetic?
Now, see, this is a very important and a very relevant question in a clinical setting as well, because miscarriages are very common. But unfortunately, in our country, we don't have robust data and publications, high quality research publications, where you would go by our demographics in our population from different areas, maybe urban, rural, I don't mind about that, but the data is missing. So whatever data we have is mostly from Western countries, where they have done research, and extrapolating that data into our setting may not be right. But yes, I mean, miscarriages happen at different stages of pregnancy. And the reasons are different at different stages. Now, as far as genetics is concerned, the first 12 weeks of pregnancy, if the miscarriage happens repeatedly, then yes, there may be an underlying genetic problem. That's a very, very common condition. In fact, 40% of pregnancies which are lost in first trimester, which is before 12 weeks of pregnancy, are because of genetic conditions. And those may or may not be picked up. Now, unfortunately, again, it needs a lot of education for families, couples, and even medical fraternity to drive them towards doing genetic testing earlier so that the problems are identified and appropriate counseling happens. Because there's no point going through the trauma of repeated miscarriages and then eventually realizing that, oh no, we should do genetic testing. So I would be, in fact, someone who would rather take a little more proactive step and offer them at least that there is this option. Whether they want to take it at first or second miscarriage is a different story. First, of course, I don't offer, but second onwards, I can offer them. Because first can be a very sporadic event which happened for no reason. But if it happens second time, first trimester miscarriage, you can start talking about it. Medically, literature would say 3 trimester, 3 recurrent losses, and then you should offer. But again, these data come from a different country, different demographics, different health economics. The countries where this comes from, the health economics are different. The government spends on the money. So they put economics into equation and then see what makes more sense, doing it second pregnancy or doing it after third pregnancy. For us, that's not an issue. We can always offer them at second, which we do. And genetics has a big role because genetics is one of the biggest contributor, chromosomal abnormalities or genetic causes towards first trimester miscarriages if it happens repeatedly. So yes, that is one most common condition, and then we have this unknown causes as well, which is a big thing. You can't always have a situation where you can explain why it happened. Then there are uterine anomalies or congenital anomalies of the uterus, developmental structural problems. And later in pregnancy, once you cross 14 weeks and beyond, then those are called mid-trimester miscarriages, where one of the commonest conditions is weak cervix. That's cervical incompetence. Again, cervical incompetence is not something which I like using, because if you say someone that your cervix is incompetent, it doesn't go down well with anybody if you say any part of your body is incompetent. So I'd rather use cervical weakness. So the cervix is weak. That's more easily acceptable by anybody when you say them, and that's true. So the cervical weakness, that cervical incompetence, which in medical books you'll find that word, that's a very common condition where 14 weeks and beyond, if the pregnancy is not growing and it kind of just spontaneously comes out and miscarriage happens, then that is because of weak cervix. That's not to do with genetics. There, the treatment is different. But for genetics, yes, there's a huge chunk of women who have genetic abnormalities. And again, in this part of the world where I am now, I see a lot of consanguineous marriages, wherein marriages happen within the families, and those are the couples who are prone for or likely to have miscarriages because of chromosomal abnormalities, or not as much structural abnormalities, but yeah. So those are the couples who need counseling and maybe genetic testing. So there is a huge role for genetics in early trimester miscarriages. Yes.
Yeah, I was actually going to ask you how many of them are consanguineous. Because we see a lot of them, I think, families that are couples that are actually related, and therefore they come and they have mutations that are likely to actually cause a problem for them.
Yeah.
So I think, one of the interesting things I've noticed is that the OBGYN field is the one that has actually adopted genetic testing after, for instance, oncology. I think the OBGYN field is the one that has actually started using genetics quite a lot. And I think it is also, like you mentioned, that you're not saving one life, you're saving two. And I think, when you do have an access to be able to figure out how it affects those both the mother and the child, I think it becomes a lot, lot more valuable for the whole family in the first place. Right? Now, the other thing you also mentioned a little bit about counseling, right? Like you said, when you're looking at consanguineous marriages or looking at people who are having, recurrent abortions and things like that. How important do you think genetic counseling or genetic counselors, what role do they play in terms of helping these families that you normally see?
I mean, they are the cornerstone, isn't it? They are the key members. I mean, it is a multidisciplinary setting. I'm not a trained geneticist. So wherever I have a situation where I think it is to do with genetic or chromosomal problem, I guide them towards the geneticist who we work with. And that person takes care, because it's a vast specialty in itself. It's a massive field in itself. So they take them through the whole situation as to what are the recessive conditions, what are the dominant conditions, and what are the chances of recurrence. Because see, once a miscarriage happens, at some point the couples accept that it has happened. It is traumatic. It was traumatic emotionally and generally also, in terms of time and resources also. But eventually they move on. But when they move on, the first question they have is, what are the chances of it happening again? And how do we get the answer for that in terms of percentages and in terms of reality as to how do we go ahead and how do we plan and how do we make sure that it doesn't happen again? Now, unfortunately, there's no answer where we can say that it doesn't happen again. I mean, we can't say that. There's no treatment for it. But yes, counseling has a massive role, and that is where the couples will get answers to all their queries as to how to proceed. I mean, there'll be exceptional situations where, for example, it's just going to happen because of whatever the underlying condition. They can then start thinking about artificial insemination by donor or a oocyte donation donor or sperm donor, depending on the underlying condition. So counseling, of course, is the key. Geneticists are the cornerstone of these kind of conditions where their input is very essential. But I don't think that is as massively practiced as it should be, because either there is lack of awareness amongst couples, or people, or even medical fraternity is not kind of driven towards doing it. I'm not sure, but I'm just wondering if that is one of the reasons.
Yeah, I mean, we're seeing more cases these days, both referrals by the medical community, but also, parents who are in general worried about, about the babies, right?
Yeah.
But it is still not quite enough. And the worst, I think for me, what worries me is that, people come sometimes after 2 or 3, and I think it can have a psychological impact on the families as well, right?
Yeah.
If they could do it earlier, then maybe there was a possibility that, they would be able to get healthier offsprings in the first.
Yeah.
Now, there are, I think the largest type of genetic tests also happen in the OBGYN space, right? Because you have the ones that you can do before someone plans a baby, then you have tests that you do during the course of a pregnancy, and then there are tests that people can do post, like a newborn screen and things like that. I've started seeing that like NIPT has become like quite popular these days, because I think, compared to when I was pregnant, that was in like early 2000s. I think there was no NIPT then, right? I mean, at that point, I think you could only do a double marker and triple marker test and so on. So do you think that, like during the course of your career, you've seen that those whole NIPT and CMA getting more popular over the last few years? I know that the carrier screening is not yet as popular in terms of like every person doing it, but I think NIPT has sort of started to become more standard, at least in the urban areas. Not so much, I think, in rural. But what are your thoughts on that?
It's true. I mean, in my practice also, I see so many women who need NIPT, and almost every clinic I'll have at least 1 or 2 women who probably have had a high risk or intermediate risk at double marker screening and NT scan. And they are counseled. I counsel them for amniocentesis as well as for NIPT. That's the option they have. The beauty of NIPT obviously is there is no risk of procedure-related miscarriage, as opposed to amniocentesis, where there is, although it's only 1% risk of amniocentesis related miscarriage, that 1% chance also most couples don't want to take, although it will give you more of a definitive answer. But NIPT, yes, certainly it has become very popular. I don't think it's only in urban areas, even if you go to district places, I think, because initially we used to go a lot in district places to give lectures and talks. Even there, the consultants and gynecologists are aware of this, and I think tests are available there as well, or they are outsourcing to the cities and getting the tests done. So unless you're talking about rural areas, really, I think district and second tier cities and even district places are doing very well. NIPT is here to stay, and it definitely is a very helpful test when you have a situation where someone is high risk or intermediate risk for this double marker screening, for first trimester screening. So yes, it has a big role and it is here to stay.
And are you also seeing that there are more adoption of tests like a chromosomal microarray, or those are much lesser, I guess, in terms of, because you're going through a certain process and get there. I think we're seeing a lot more people who are adopting an NIPT because, like you mentioned, I think you're taking the mother's blood instead of taking like a, for whatever reason. But I think it's still people have to realize it's still a screening test, and if it does come positive, you probably still have to get a confirmation from an amniocentesis anyway. But I think it helps taking out a lot of fear for a lot of the parents, I guess.
Definitely helps, yeah.
And do you see that, newborn screening, obviously, I think there are many use cases for that, right? Like, I think especially because you are in the UK, I think, for instance, the phenylketonuria and others have become, I think, part of the standard process for babies when they're born. It doesn't yet. I mean, I know that the Indian government, right now, I think they created the Nidan Kendras and others, but it's still not become part of our, regular screening, right?
Yeah.
But do you think that if we did screen all babies at birth, I mean, assuming that, budgets were not a problem, what percentage of lives would we be able to save? I mean, is that a sizable number of babies that we would be able to save if we were able to do some small interventions? Because I think like in a phenylketonuria, it's mostly a diet related thing. There are certain interventions that you can do as a doctor that are much easier, and you can save lives of a lot of babies. So do you think that it is something that's worthwhile for a government to sort of think about how do we actually implement newborn screening, and will it make a big impact in, would it be 100 killed children, or would it be 10,000, or would it be in millions?
That is where my earlier comment about robust data from this country becomes relevant, because for these things to be implemented as welfare schemes or as health schemes from government level as well, we need to have some robust data to present to them to say that this is what the statistics is, this is what the demographics are, and this is what the numbers needed to treat is. So this much you spend to identify one kid with a problem. So how many will test positive after how much of screening? So those data, those statistics is what becomes relevant. Now, as an obstetrician gynecologist, I don't have those kind of volumes which I see. But apart from one or times when I sit with my neonatologist and talk to them, they tell me about these conditions. But we don't necessarily see these babies once they are born. Once they are born, they are handed over to the neonatologists and the pediatricians. They take over the care of the baby, screening and all those things. But to answer your question in terms of whether they should be implemented at a larger scale and from the government, what the government, I would imagine, will want is data. You give us the data, give us the figures, let's put economics into it, and let's see if it makes sense screening, and what kind of screening. Should it be a high-risk population screening? Should be a particular screening? Who are you going to screen? I mean, universal screening, again, will make sense, but what are the economics you're looking at? So I think there are lots of things which will need answering before it comes to implementation.
I mean, I guess, now there are several countries that have started doing that, but at least once it has been implemented in certain scale, or the government, realizes the importance, I think we'll see that at least amongst the largest hospitals, I think we've already started seeing that more and more newborn screens are happening, at least at the biochemical level, right? I think at least as far as I know, Rainbow probably screens every child that is born, who's born. So I think, there are some, great initiatives by some hospitals, but I think it probably would be great if that can be.
Rainbow is the in a way, what shall I say, the leaders in childcare nationally and even internationally. We are making our mark. So Rainbow is something which they're setting standards. We are setting standards, particularly in childcare and neonatal care. There's no doubts about that, and we're the kind of leaders in the specialty in the area. But I think you are also very well placed to make these happen in terms of more and more screening. If you also liaise with whoever your clients are and get the data and present it to the government or present it to the stakeholders, including big corporate hospitals, and make a case for this. But I think you are better placed along with neonatology colleagues than a gynecologist, I think.
one of the things I remember at least during my pregnancies, I remember that, they really start looking at things like diabetes or cardio, a lot of the screening that happens, the most painful, the one where you keep drinking a lot of glucose, the glucose tolerance test and other
Yes,
such
yes,
tests, right?
yes.
Now, do you think that if we understood a genetic predisposition of these women before they did that, it would be easier to be able to understand that they are the ones at a higher risk than the ones that maybe are not, right? If you look at their family history and you look at their genetic predisposition, then maybe there's a possibility of being able to say that these are higher risk category compared to, let's say, somebody who's doesn't have that risk, is younger, because ultimately these are all risk factors that are there. Do you think that also comes into, can become part of the process of saying, if I'm looking at an overall risk, is genetic?
To be honest, I mean, that is a very interesting concept you're talking about, getting genetic predisposition and a profile in terms of high risk and low risk. But eventually, if someone turns out low risk, even then we were not going to ignore them and not do the test. That's one. Second is there is that the screening that happens anyway when we see the woman first time in our OPD, outpatients. I would ask her family history of diabetes. That is just an inherent question which I will ask always when I'm taking history of seeing anyone first time. So parents and trust me, I mean, I wouldn't be exaggerating if I say 6 to 7 out of 10 women who I ask family history, they have diabetes. 6 to 7, either one parent is diabetic or both are diabetic. And their parents are in the range of 45, 50, or 50 to 55 maybe. So point is, there is a lot of diabetes there, and genetic predisposition definitely is there. But again, it will be an interesting concept. I'll have to really read or learn more about how this can be implemented into clinical practice. To be honest, I have not come across high quality articles working on that direction, or I don't know about countries which are doing this. And as far as glucose tolerance test is concerned, I know it's not something which is a very pleasant test to have. But in pregnancy, believe me, you just tell them to do whatever and they'll do it. You just tell them this is what is needed for the baby, for the pregnancy. They'll say, okay, fine. Tell me what I should do. I'll do it. They're so motivated. They're so driven. And they're so energized that they want to do it. And they'll do it. But yes, avoiding that particular test will always be a welcome step, provided we have some high quality evidence telling us that this is an alternative, which is far better. That's how we are moving, isn't it? In any medical specialty, in any area, may be my endoscopy work, which is my first love, if I may say. Endoscopic surgeries is what I love doing. So even there, we are advancing, we are progressing by seeing some high quality work by colleagues from other parts of the world, from our own country, from our own state. So there are people doing a lot of good work. We look at their work, we look at the evidence, we put that into our own perspective and say if that is going to be helpful to my patients, and then we implement it and we learn those things and implement them. Likewise, in this also, we need to see some high quality papers and evidence before we start saying that this will be an alternative which we can put to our patients.
We recently published a paper in Nature on exactly this. So I will send that across to you.
So please share it. That will be great. Good to see you. Certainly.
So that's why I was thinking that, if there's a way, because I definitely have a genetic predisposition.
Yeah.
Both my parents, but I don't have I keep my HbA1c in very much in control, because I'm aware that that is there in my family history. Right? And therefore, I think, people who are aware are more likely to take action. So I think that's what I tell a lot of people, that you can change. Your genes are not your destiny. It is more like, if you understand it, then you'll be able to.
Certainly. No, definitely, yes. And screening also happens on their habitus. The moment you see them BMI, the moment you see their metabolic, I mean, there will be someone who was with us for infertility, for example, and got pregnant and continuing with pregnancy. So those women, I would have screened them for metabolic syndrome because of polycystic ovaries or their general habitus. And we know that there is a lot of predisposition from that perspective anyway, from a genetic perspective for diabetes and towards other conditions in gynecology. We're not even talking about the role of genetics in gynecological malignancies, for example. That's another area where that can be explored. But again, those are mostly taken care by gynae oncologists than by us.
But I think there are so many areas that, people don't even realize that, and a lot of times maybe when they're coming to you, they're probably the first time they're even seeing a doctor. A lot of women, I'm sure, did not, necessarily go have a doctor or before they actually go and see an OBGYN. I know a lot of women who say that, their gynecologist or OBGYN is their best friend because they can talk to them and discuss a lot of different things. But I feel that there is still a lot of things that maybe if there was a better way of being able to help them, from earlier age, maybe they would be able to make those changes in their life earlier. And you mentioned a little bit about PCOS, like a polycystic ovary. I had not realized how prevalent it was and how that can be sort of correlated with fertility. So I'm sure that you have some thoughts on that. Is that something that is rising, or was PCOS always a big problem when it comes to fertility and in terms of the number of cases that you see now?
I think in infertility, almost 30 to 40% of women who walk in infertility clinic have PCOS. The awareness certainly has increased, both amongst patients as well as amongst the medical fraternity as such, because we're seeing more and more, we're learning more and more, we're attending more scientific meetings, conferences where this is talked about a lot. So general awareness has definitely gone up, and there is this association of increased BMI with polycystic ovary. Which one comes first, which one leads to what, we don't know. But these women also have metabolic syndrome. Now, unfortunately, metabolic syndrome screening is not what is done in most clinical settings. They're only focused on infertility and how to get them pregnant in terms of ovulation induction and so on. But what they also need is metabolic syndrome screening. What they also need is lifestyle education, lifestyle changes, which they desperately need. And you need a right lifestyle medicine consultant to guide them through dropping weight and maintaining healthy lifestyle. Unfortunately, most women, they seem to be very driven initially, but at some point they get lost and they're the same again. When you see them back in 6 months or a year's time, they're not changed much. They'll tell you the whole story, that how they started, how they wanted to do, but then eventually gave up. I don't know the reason for that, but I think they didn't get the right guidance. That is what I believe.
Yeah, I think a lot of people tell me, why do you keep losing? Why do you want to lose weight even more? And I tell them that, weight loss is not just about how you look. It is a lot to do with your health as well, right?
Absolutely, absolutely. Oh, obesity is bad. It is bad. It brings with you a lot. It brings with it a lot of problems, including non-communicable diseases, primarily hypertension and diabetes and metabolic syndrome, which is really bad. Your lipid profile completely changes and becomes very unfriendly. And that is why we are seeing many women having all these problems in early 40s or late 30s.
Yeah, and I think, that's what I'm telling them. I'm now in my 50s and I want to remain in my 50s in terms of weight.
Sure. Same here. Yeah.
I think that it makes it easier for like us to, go on this journey of health if you're able to maintain health, maintain your weight as well as exercise, because I think that has a huge benefit when it comes to your overall health. So what are the other areas that you feel that, you're obviously seeing a lot of, people who are going for IVF treatments. There are a lot of cases when it comes to fertility. I think it has become a huge area of, different kinds of health concerns. So in terms of, things like anemia, or in terms of, we discussed a little bit about PCOS and others. What are the other things that women should be aware of when it comes to their fertility health, if I can say, and their other, other potential risks like anemia or PCOS and other things? Is there anything that you'd like to tell our audience?
There are, again, it depends upon where you're practicing, what your clientele is, and what the demographics is. If you ask me, the education should start right from sex education. when you talk of fertility also, the fertile days, the safe period, and so on, the contraception, delaying pregnancies, and there's a lot of myth around as well. There are lots of people who have lots of myths, which as and when I get chance, I try to identify those myths and try to bust them. And then there are a lot of, what shall I say, unawareness about the implications of health issues in pregnancy. Especially when you talk of diabetes, for example, hypertension, obesity, these are the issues which people kind of tend to miss. They feel pregnancy is one thing, these are other things. No, when you get pregnant and if you're obese, that has implications. Now, I operated on someone recently who was 149 kgs. She's 149 kgs and got pregnant. And so she went up to good 160 kgs. I mean, it's not ideal situation for any doctor also to deal with that kind of situation, because your pregnancy is at risk, your baby is at risk, your health is at risk. If you have a normal delivery, well and good. If you have a cesarean section, there can be a lot of complications with cesarean section as well as recovering from cesarean section. So optimizing health is what is most crucial. So every obstetrician and every doctor, even non-obstetrician, even physician colleagues, for example, wherever they identify that a particular woman has diabetes, for example, thyroid or any medical condition, that should be optimized first before you embark on pregnancy. Unless your baseline kidney functions, baseline thyroid, baseline sugars, all are normal, you should not be embarking on pregnancy. So it's very crucial that you optimize your health and then plan pregnancy, because pregnancy will bring a lot of additional burden on your body. If your body is not in correct shape or correct physiology, it's going to be unable to cope with the burden of pregnancy, which will only make your health miserable, and pregnancy outcome also gets into jeopardy. Therefore, optimizing health, those are the two crucial words which we should be emphasizing and instilling in women's minds, and the family is most important. So they plan pregnancy. In fact, my advice will be to do a pre-conception counseling with a doctor. Do a consultation prior to planning pregnancy, get yourself screened, make sure you're in good health, and then say, okay, now can I plan pregnancy and what are the precautions I should be taking? Or are there any medicines I should be taking, or are there any supplements I should be taking, or is there anything I should be doing before planning pregnancy? And then you embark on pregnancy. So pre-conception counseling is what it is, or pre-conception consultation. One visit will help you a big deal, I think.
Absolutely. I think that's like the must, right? I think most people don't realize that is so crucial, and they usually go to a doctor after they are pregnant.
Absolutely. And then the doctor finds that she has diabetes, she has thyroid, she has blood pressure problems, so she's obese. I mean, these things don't help. Eventually, we have to do whatever the best, but that's not the ideal situation to be in.
So I think, maybe one thing that we can get out of this conversation is we should, inspire more women and more families to go and see a doctor before they are planning a pregnancy.
Absolutely, yes.
Get a health screen, get that checked, and then only plan.
Okay.
So I know that, with you, I think we can continue talking for a long time. But I know that we are coming close to an hour. But I'm very curious about, a little bit on, you're a laparoscopic surgeon. What is laparoscopy, and how does that help in your field?
Well, laparoscopy is something which is also called as minimal access surgery, which means in traditional good old days, there used to be big, large cuts on the tummy for doing any surgery. These days, we do it through keyhole surgeries, which means small little 5 millimeter, which is as small as a peanut size or a cashew size incisions. And we can remove big tumors or big diseases from the pelvis, from the tummy. The beauty of these surgeries is it gives a very little pain after the surgery. It causes less blood loss. It helps you recover very quickly. Especially working women can go back to work very quickly, or nursing mothers, or those who have young families, they can look after their families very quickly. And in long term, we call adhesions, meaning when the tissues get stuck inside. If you have large cuts on your tummy, tissues inside also get adhesions, meaning they form like curtains inside. That is a long-term morbidity which these large cuts give. With minimal access surgery, laparoscopic surgery, that is completely negated or minimized. And most importantly, again, cosmetically, these are very good, because nobody wants a big scars on their tummies. They would rather have small little 5 millimeter or 10 millimeter incision, which is a centimeter max incisions on their tummies, and get on with their lives more quickly So cosmetically also it is very beneficial. So there are lots of benefits this minimal access surgery laparoscopy comes with. And these days, almost everything that could be done by open surgery can be done via laparoscope, depending upon the surgeon who's doing it, depending upon your gynecologist who's doing it.
I think that's great. I think a lot of pain can be avoided with that.
A lot of pain yet, trust me.
Let me move to something. I know we've discussed little bits of this as part of our discussion, but what is prevention according to you? If you had, tell this to your patient, you said that you wanted families to come before they plan a pregnancy, for instance. But if you just had to generalize, what do you consider as prevention when it comes to health?
See, we live in a society where we are exposed to a lot of information. May it be your social media, may it be your friend circle, may it be your work environment, may it be your work colleagues, and so on. And with this mobile phone, with the WhatsApp information coming, you have to be very careful about what's really genuine, what's fake. What I'm trying to hint at is we are already exposed to so much of information. If we use our logical mind and think about what really is harmful, what really is good for our health, it's not difficult. Now, generally, as I'm saying, the whole world knows smoking is bad. We all know that you can drink, but to certain limits, maybe otherwise better not touch alcohol at all for whatever reason. Then there are certain things like putting on weight, just getting your BMI optimized, identifying your family and seeing family risk factors and seeing whether you are at risk. Get yourself genetically tested if need be. Don't shy away from those things and don't be in denial. Many times people know there is a problem, but they want to be living in denial and just want to kind of run away from it. Face it and then say, okay, fine. So essentially, we have lots of areas where we know are bad for our health. And just make sure that you don't get in the trap of those habits or addiction where your health is at risk. So essentially identify those areas and don't go near them is the best way of preventing and keeping yourself in good health. That's how I look at it. And these days, this gym culture also is coming up. I'm seeing a lot of young people that are trying to play some sports or do some activities or go to gym or at least pretend they're doing some dieting. So continue doing that. And that is how you're going to prevent certain things or most of the things and look after your health.
And how can we age better, or what do you consider as healthy aging?
I'll tell you what now. Incidentally, my wife is a lifestyle medicine consultant as well. She's an anesthetist and lifestyle medicine consultant. So from her, I get a lot of information about dieting and generally health style habits, and good food and the right nutrition and all these things. So all these things which I'm saying, this information is very important. There are only two things. One, what you eat, that's in the kitchen. Second, what you do in terms of work in the gym or outside gym, doesn't matter, but physical activity. These are the two things eventually which will make you grow more graciously if you take care of these two things. I have known people, and I myself can tell you that you can reverse your diabetes by lifestyle modification. You can reverse your blood pressure also, although it is a rare thing. But I can tell you by my own experience that I have stopped my blood pressure medicines for more than a year now after working on these things seriously. So obesity, I'm sure, I mean, weight one can drop as well, which many people will vouch and give experiences about how they have dropped weight and how they have maintained within that 1 to 2 kgs of margin. So there are a lot of things you can do to kind of age gracefully and essentially by trying to keep good habits and minding what you eat and how much you work out. Those are the two things. It's not very difficult. In 24 hours, you can always give 1 hour for your body. 23 hours, you do what you want to do. Sleep, eat, work, do what you want to do. 1 hour give to your body. Take it as a physiology, like you breathe every day. You just tell yourself that you want to do exercise. You want to not sit idle. And you should be able to do that. I mean, how can you not give 1 hour for your own body, which is going to be with you forever or until you last? So it's very simple to tell yourself certain things.
So what is your favorite kind of physical activity or exercise that you do?
I'm quite a regular gym goer. At least for the last 2 years, I've been going to gym quite regularly with a personal trainer, and I think I'm happy with the way things are going in that particular area. So it again depends upon your own personal goals as to what you want to set yourself. There are lots of things. Once you have a proper trainer, you know what can be strength training, what's cardio, what's core, and all those things, all the rest of the things. So you choose what you want to do in terms of your goal settings, and if you're motivated enough, you will get there. So yeah, gymming is what I mean. Otherwise, I like chess a lot. I played chess at quite a high level in district and university levels, and I do still play chess off and on. But that's not something which is physical activity. So as far as physical activity is concerned, yeah, as far as physical activity is concerned, it's the gym which I think would help many people, and certainly does help.
That's great. So I think if somebody like Dr. Niraj, who is so busy, sees so many patients during the day, can find time to exercise, go to the gym, lift weights, and also eat mindfully, I think all of us can, right? And I think that's one thing that everybody should pick up from there. So I know we touched a little bit about myths, and I'm sure pregnancy comes with a lot of myths. So can you tell us a couple of them which you find the most amusing, or something that which obviously aren't true, but which ones are the ones that people should be aware of, that they are commonly available across as knowledge, but they're not true?
Oh, there are a lot of things actually. One of the things which I really find very intriguing, interesting is people ask me, can they eat this kesar? The reason they will say is they want light colored
I was going to say
of the child. And I'm like completely stunned. And there are so many of them asking this question because their elders have told them to do it. I mean, how can that be possible? So then I sit and tell them that I worked abroad in London for 12 years. And I've always seen white couples will have white babies. They've never sat and ate kesar. Or an African black couple will have black babies. No matter you give them truckloads of kesar to eat, they will still have the skin color which their parents have. Likewise, brown skin will have brown skin. So no matter what you have. So that is one myth which I have found so amazing. Second thing is about papaya, for example, that or even before that, they putting this cotton buds in the ears. Once the mother is delivered, they all put cotton buds in the ears and put a woolen muffler around the head and tie it so that air should not get in their ears.
Why?
Because apparently that is bad for a just delivered lady, because it gives whatever headaches and things. And when I tell them that, are you able to hear what I'm saying? And they say, yes, I'm able to hear. Then I say, that means air is going in your ears, which means the whole exercise of putting cotton wool in your ears and tying the muffler around your ears is a complete waste of time, because you're able to hear. Tell your elders or whoever has told you that you're not stopping air getting in your ears, regardless of whether you put the cotton wool or not. So what kind of sense does that make? I mean, trust me, I see 7 to 8 out of 10 women who have this cotton in their ears the moment they've delivered, because air should not get in. And I'm like, why have any panga with air? Because it will go through nose as well as mouth, and they all are connected. So you can't stop air getting in. So there are lots of, these are myths, but they carry on. That's interesting. Then they don't give, you tell them to take high protein diet. Many women will say they're not allowed to eat this food, especially dal, pulses. And I tell them those are nice high protein food, which you need because you're recovering and you have wound and you have sutures, and it's high protein is what is needed for wound healing, good wound healing. And pulses is what have nice proteins, but they're not given pulses because apparently those eating pulses will cause the wound to get infected and pus collects in that. Now, these are myths. There are a lot of myths out there. I mean, in fact, I have my website where I have put a section of myths and truths, where people can just go and click and see what myths. And there are lots of myths which I come across. These are randomly coming thoughts I'm telling you, but there are a lot of them which I can sit and enumerate. So but in fact, now it has gone down generations.
What website is that? We can link that in the video.
Sorry?
So what is the link for the website? We'll put that.
It's NIPT.com.
Okay.
At the moment, it is under construction again. I've just for the last 2 weeks or so, but it's going to be up and running in a week's time.
So I think people can have a full look at all the myths that are associated.
Yeah, myths, and that goes by NIPT.com is what it is.
And I know you mentioned that, one of the things, and I think that people should come before pregnancy to plan for their pregnancy, making sure that they get a clean sheet of their health before they plan one. But are there any other things that women should be aware of before they get pregnant? I mean, other than the fact that they are in generally good health, what lesser known facts or insights can we give them?
One of the most important things I would tell them is do not touch Google and try to find answers for your pregnancy or problems in your pregnancy there. Because that information, you never know where it is coming from, how valid it is, how much it applies to your health. But these days, the problem is you can't stop people. They are all carrying Google in their pockets. They come here with a list of things which they feel they already know. It's like I reading about how an aeroplane flies on Google and thinking that I know how an aeroplane flies. It doesn't work like that. They come here thinking that they know how things work in their body. No, it doesn't. We have spent years learning about medicine. Then we have, after qualifying also, even today, we are learning new things when we see new situations or new clinical scenarios. So one of the things I would tell them is do not go towards Google, do not read online, do not go and search YouTube, because there are very scary stuff out there. The moment you read those things, you always start thinking that that is also happening to you, when actually it may not be. But the moment you read it, you start and think that it is happening to you also, and it is always a bad news. So that is one thing which you should never do. Second, never talk to people who have no idea, but they believe they are doctors. They'll give you advice for free, and that always is completely non-scientific and a myth. Now, all these myths which I said, they come from somebody who they have heard telling, or someone has come and given them their advice that don't eat pulses during pregnancy because it causes pus or infection. That is a myth. So do not talk to people who are non-medical people and who are not qualified to give you any medical advice. That's the second thing which I tell them. And generally about good health and good diet and good exercise. Don't treat your pregnancy as a disease, because pregnancy is not a disease. The moment they get pregnant, either they themselves or family people start putting inhibitions on them, saying, ye mat karo, wo mat karo, don't bend like this, don't sleep like that, don't do this exercise, don't go to work. There are lots of things. And I tell them, don't treat pregnancy as a disease. This is something which is normal. Enjoy your pregnancy is what I say. And keep minimum supplements. Try and take more healthy food and try and take healthy nutrition. Let your nutrition come through food and healthy stuff out there than taking 10 types of medicines and biscuits. Because you believe you need those kind. Of course, there'll be women who need supplements. I'm not saying that it's not needed at all. I'm saying everyone does not need that. If you are in good health, if you have your well-balanced diet, you don't need much supplements. You may need iron and calcium because the demands are very high in pregnancy. But by and large, if you're in good shape, good health, and your diet is well-balanced, you're fine.
I think a lot of people need to understand that, a lot of things can be obtained through your normal course, as long as you are aware that you can get a lot of your vitamins, your minerals, and all from your food, as long as you're eating that. So we'll move on to the rapid fire round.
Yeah.
Short. The short one, nothing to do with gynecology or genetics or anything. So what is your most common complaint by your friends about you?
Don't call them often. Don't talk to them often.
I think that is, you're busy. I guess that explains. What is something that you would want to do less of and something you want to do more of, if you had the time?
I didn't get the question. Sorry, what did you say?
What is something that you would want to do less of than what you're already doing, and something that you would want to do more of than you're already doing?
I want to travel more, which I'm not at the moment, I believe, but that's one thing which I want to do more.
And anything you want to cut down on or do less of? Or?
No, to be honest, I'm doing everything optimum, I think, so I don't want to cut down on anything. It's all well balanced.
Okay. What's your favorite food?
Favorite food? It's nice chicken curry. From Vidarbha, there's a dish called Sauji chicken. That's my favorite, but I don't get in this part of the world.
That is from where? Where is that from?
Vidarbha, Nagpur.
Vidarbha. Okay.
Yeah.
That's where you said you did your MBBS from. Right?
Yes.
And your favorite place to go? Not Nagpur, I'm hoping.
Favorite place to go?
Favorite place to travel to?
London.
London.
Okay. Yeah, that's where my son is, and that's where we spent a lot of time. So, yeah.
That's great. Anything else that you'd like to add? Otherwise, I think we went a little bit, much more than a little bit beyond
That's fine.
that I took from you.
Yeah, that's not a problem.
But anything else you'd like to tell the viewers, or we would then call it a close?
No, I would only say that it's not very difficult to keep yourself in good health. Just two things, as I said, I emphasize again. We all have 24 hours. Try and give 1 hour for your body every day. Maybe you can make an exception and have a cheat day on Sunday or Saturday or any one day of a week which you want to. Fair enough. But 23 hours keep for everything else. 1 hour keep for your body. Eat healthy stuff and keep good habits. Stay away from bad habits. And optimize your health before you plan pregnancy, because that's as a doctor I'm telling you.
I think those are absolutely fantastic things that you just told us.
Yeah.
And I think everybody should listen to them and make sure that you are, you place your health a little bit more than what you would place on your children, your family, your education and everything else. Because if you don't have health, you don't have the rest
Absolutely. Because your body is aging. It needs, for our vehicles, we do servicing every year or every 6 months or whatever on a regular basis. How can you not look after your own health? And that's a simple question one needs to answer. When everything needs maintenance, your AC needs maintenance, your house needs maintenance, your vehicle needs maintenance, so does your body. And your body's maintenance is look after it every day.
Absolutely. I think with those words, thank you so much, Dr. Niraj. I think it was an absolute pleasure. I think I could have spoken for another couple of hours, but maybe we'll leave that for when you come to our lab and have that part 2 of that discussion. Because there are things that we can discuss about, I know we touched a little bit about, how when pregnant, when women are pregnant, the babies also carry some of that information, whether it is your epigenetic information or things like your microbiome. But we'll leave that for another day. So thank you so much. It was an absolute honor and pleasure to have you on Genomics Gupshup, and thank you very much.
So thank you as well. You've been wonderful, and I didn't realize it's almost 1 hour or over 1 hour. Honestly, you've been wonderful as well, and you didn't grill me too much with difficult questions. So I think I also enjoyed the session a lot, and you've been wonderful. Thank you very much for having me on your show.
Okay, thank you so much.
Thank you.